Hi, how are you today? I'm MarkColeRomig from the Johns Hopkins Hospital and the Armstrong Institute for Quality and Safety. And I want to tell you what an honor it is to be able to speak to you today and talk to you about what we're doing at Johns Hopkins. And I'm going to talk to you today about a project that we call Emerge. Emerge is actually a joint project between Johns Hopkins, the University of California, San Francisco, along with the Hopkins Applied Physics Lab doing the engineering, and is generously supported by the Gordon and Betty Moore Foundation. And Emerge is a project in which we're trying to emulate other high reliability organizations to eliminate preventable harm in the ICU. So when we think about other high reliability organizations, we sometimes think of aviation. Aviation has very few accidents in any given year, typically none, compared to healthcare, where we have about 200,000 people who die from preventable harm. So this is the equivalent of about 4 747s crashing weekly in the U.S. And as you can imagine, if we were crashing 4 747s weekly, there would be an uproar and we would halt all aviation until this problem was solved. But at this point, we have not reached this aim in healthcare. So why are we looking in the ICU specifically within our project? Well, it's kind of low-hanging fruit for us. So 80% of all people will be have contact with an ICU at some point in their lives. And about 1 in 5 people who come to an ICU will actually sustain some sort of serious harm. And mortality rates are very high in ICU, somewhere between 10 and 20%. And the costs are also quite high as well. So if you look, 1/3 of all healthcare expenditures are on inpatient care. And even though ICU beds only make up about 8% of inpatient beds, 1/3 of all that, 1/3 of all those costs of the inpatient care come from the ICU. So 1/9 of our healthcare system is ICU care. To put that in perspective, that's about 2% of our GDP. And part of the problem that we have, and I think some of our speakers have already alluded to this earlier, is the lack of productivity that we have, or the lack of gains in productivity that we have within healthcare. So if you're a large telecom company, you're experiencing somewhere around 8% improvement in your productivity from year to year. Healthcare is nowhere near that. And if you look at this top blue line, that's projected U.S. healthcare spending. That bottom green line, that is just making an assumption. If we were able to improve our productivity by 4%, half of what telecom can do, we would experience great rewards in terms of costs. So we sort of backed up and said, how do we address this problem? And we really believe that this is a systems engineering problem. And if you're going to try and design a system which is safe, you can't try and add on safety after the fact. You need to really start at the beginning. You need to go back to the initial implementation, design safety into the system. And currently, our systems aren't very safe in the ICU. None of the machinery talks to each other. None of the devices are integrated. And it's a really poor human resource management. And I'll demonstrate some of that momentarily. I'm going to skip this slide for time. So, and again, going back to my aviation analogy, what kind of things have we seen in aviation? Well, aviation has really latched on to this idea of integration. So if you look at a cockpit from the early 1980s, that top right corner there, you can see the cockpit was very cluttered, very difficult to use. And over time, through integration, through design, the cockpit's gotten easier to use. Now, if you look in the bottom, you see that's what a hospital room looked like in the 1980s. And this is what it looks like now. So it's no better. It's actually quite a bit worse. And every single none of those devices talk to each other. And we as clinicians have to do all of the integration that comes out of those devices. And every time we add a new device, a new fantastic technology, our life gets harder, not easier. So I'm going to talk to you a little bit about Emerge, and then I'm going to do a brief demonstration for you of what Emerge actually is. So going back to the idea of designing for safety up front, what we really started with was the idea of a CONOPS, or concept of operation. Those of you from the DoD here are probably familiar with this. This is a very new concept of healthcare. And really what we did is we categorized all of the resources, capabilities, personnel within the system, and then came up with and then looked at those with our goal of how do we eliminate harm within healthcare. And we came up with this kind of 4-step framework. One is, how do we assess who's really at risk for harm? The next is, how do we identify the correct therapies that patients should be receiving, and are they receiving them? How do we ensure that the therapies are being reliably delivered? And I think the part that we tend to miss out on the most is monitoring performance. So we say we're doing all these things to make our patients better, but do you really know if your patients receive the therapies that they're supposed to be receiving at any given time? And even though I said that this is a model that we've put forward within the ICU, this model is not ICU specific. It just happens to be where we're trying this right now. This is a generalizable model. This could be used anywhere in healthcare, inpatient or outpatient. And something to keep in mind, is I'm going to be talking to you a lot about the technology portion of this, but this is not just a technology project. If we just brought technology to the table and foisted it upon the end users, I can guarantee it wouldn't work because it's not designed around their needs. And so eMERGE was really designed from the bottom up with the end user in mind. When I say the end user in mind, they were at the table. They were the ones actually doing the design work with the human factors engineers and systems engineers to design a system that would work for them. And so you really need to have a solution that's at the intersection of this culture, technology, and workflow. And around that, as some of our other speakers have already discussed, learning and accountability is a big part of this. So to give you an idea of what eMERGE is, eMERGE is actually a platform which is able to ingest data from multiple data sources. So we refer to it as an agnostic system. So what that means is we don't care where your data is coming from, but we'll take it. Is it coming off a machine? Great. Is it coming off some novel sensor you've created? That's fine. Is it coming out of your EHR? Great. Is it just personal input data from clinicians? We'll take all of it. And then eMERGE is really just a platform that allows us to spit it out in multiple different ways. So what I'm going to show you today is the clinician dashboarding, but we also use this for patient family portals. We use this for dashboarding for administrators and potentially as a research database. So so we actually are addressing 7 harms within Project eMERGE. I'm just going to talk to you about one of them today, and that one is ventilator-associated harms. And there's multiple components to ventilator-associated harms. There's about 8 evidence-based components that we know are able to show reductions in VAE. So the first one I'm going to talk to you about, and this is actually one of my favorites, this is head of bed. And so I love this because this is a real workflow in our ICU. So we know that a patient needs to have their head of the bed elevated at 30 degrees in order to reduce the risk of pneumonia. So some of our beds don't have protractors on them. So what our nurses do is they actually create these paper protractors so that they can measure and make sure the head of the bed is at 30 degrees. So they then take that information and they go put it into a medical record. And then my job as a clinician is to go through and look to see whether the head of the bed is really being maintained at 30 degrees or not. And so I have to go through multiple flow sheets, as you see here, to find that information. Likewise, a patient who needs a spontaneous breathing trial. Again, we know that patients who get a spontaneous breathing trial come off ventilators faster and experience less ventilator-associated events. And so, again, I have to go through multiple flow sheets to try and find this information to whether the patient got a spontaneous breathing trial. And what I'm showing you here is all in Allscripts Sunrise system. Just so you know, this is not just an Allscripts problem. Daily sedation interruption, this is actually an Epic environment. So again, you need to go through multiple flow sheets, find the information you're looking for, and bring it to the surface. So you're probably thinking to yourself right now, Mark, this is a very tedious talk. You're just showing me a whole bunch of flow sheets. And yes, I am just showing you a bunch of flow sheets because I need you to understand that that's what the workflow of a clinician has become nowadays. It's literally just going through flow sheets to try and determine whether the patient's getting the therapies they should have received. And so this is just one harm we're talking about in one patient. To get the information I need, it's 15 clicks, it's more than a minute. If you blow that up to the multiple harms any one patient can experience, and then multiply that times the number of patients I have in an ICU, you can see what an enormous part of my day this becomes. And this is just for one snapshot in time. Just because it's good now doesn't mean it's good an hour from now. So, I mean, we're really dependent on clinicians' heroism to keep our patients safe, and that's not a safe environment. So now I'm going to show you eMERGE, and so this is really exciting for me. What I'm actually showing you right now is live data that I'm pulling out of Hopkins at this moment. So this is our test bed server. Sorry. And so what we so these are all anonymized data. So we don't really have U.S. soccer players in our ICU right now. But this is real patient data. And so as you can see, like most information systems, you need a way to locate your patient. And in our system, the patients are able to give us their pictures through their patient family portal. I'm not going to have time to demonstrate that for you today. But this is our solution. So what we've come up with is this red, green, yellow system to identify whether patients are getting the therapies they're supposed to get. So all of that information I showed you that gets ingested then gets put into these visual displays. So this is really creating situational awareness. Instead of me having to go through a bunch of flow sheets, it's going to pull the data I need to the top. If you can think of a fighter pilot flying a plane, you know, in the cockpit, would you want your fighter pilot going through multiple flow sheets to try and find the information about the target that they have to deal with, or do you want the information that they need to be in front of them contextualized? And so that's what we've really done right here. And so as you can imagine, green means that the patient's getting all the therapies they're supposed to be getting. Red means that they are not getting all the therapies they're supposed to be getting. And yellow means that there's a lack of information in the system. So I'm just going to, so backing up, so ideally, I wouldn't even have to look at, say, ventilator-associated events on this patient, because I already know it's green, and I already know that all of the items that need to be done are being done. But I just want to give you a quick look at this. So this is what we call our condition-specific display, and it's based on a 24-hour clock, so I can look and see not just are they okay now, but how have they been doing over the course of their day. Have they been getting the therapies they need? Have they not been getting the therapies they need? And one of the really neat things that we're able to do in Emerge is create a data hierarchy. And so what I mean by that is if there's two data points for the same thing, say I have an EHR piece of data for the head of the bed, but then I have a different piece of data for the head of the bed, say a novel sensor. I can choose which one of those data points is more important to me and have it displayed here. And that's actually what I want to show you right now is if you look at this head of the bed ring, it says the head of the bed has been continuously at 30 degrees. So how are we doing this now as opposed to current workflows? So this is actually a sensor, which I've brought from our test environment. So this is a Bluetooth device. It costs just a few dollars, and it's magnetic. So instead of having nurses now go to the head of the bed, measure the head of the bed, go to the EHR, put that information in the EHR, and then me go look for it, this device just continuously monitors the position of the head of the bed. I mean, you can see with that one device, this is just a few dollars, we've dramatically improved productivity within our setting. Not to mention, we're also improving accuracy. I don't know about you guys, but I know that there is a big problem with copy forward in our EHRs. So, you know, yes, it says the head of the bed is at 30 degrees, but does that mean that someone has just clicked forward from the last time the head of the bed is at 30 degrees? Is it really at 30 degrees? You know, now we really know. So we're improving accuracy, we're improving productivity. And we think through this system that we're improving safety. So I'm gonna. We actually don't have any data that I can show you yet. We are actually end of our first year, and we're doing our data integration. We are actually currently rolling out at UCSF in California right now. So they're just getting started with all this. But I just want to thank you guys for listening today, and I hope that this is given some food for thought for you guys moving forward. Thank you for your time.